Welcome back to the another session. The first question we are going to discuss here is torsion testis. Okay, what do you mean by the word torsion of the testis? It is nothing but the twisting. It is nothing but the twisting of the spermatic cord and its contents. Okay, that is, write it down. It is nothing but the twisting of the testis? No, twisting of the spermatic cord. Twisting of the spermatic cord and its contents. What happens when there is a twisting of the spermatic cord? There will be decrease in the testicular blood supply. So due to twisting of the spermatic cord, there will be decreased blood supply to the testis. If at all we are not untwisting this, if it is left untreated, what happens? This decrease in blood supply continues, and at one point of time, due to this lack of blood supply, the testis is going to die. Okay, testicle is going to die. That is why torsion testis is a surgical emergency. Whenever there is a torsion of the testis, you have to open and you have to make sure you have done untwisting of the twisted spermatic cord. Otherwise, what happens? Blood supply is going to decrease, and lack of blood supply, ultimately the testis is going to die. Okay, that is why torsion testis is a surgical emergency. Coming to the risk factors. So what is the most important predisposing factor? Most important predisposing factor for torsion testis is high investment of tunica vaginalis. Very important point. High investment of tunica vaginalis, called as bell clapper deformity. Bell clapper deformity. This is the main predisposition for torsion testis. So what is this bell clapper deformity? For that, before you should know how a normal testis is going to be. Let us assume this is your tunica vaginalis. Okay. And this is the testis. So this is how it has to be normally seen. Okay, this is a normal one. But what happens in bell clapper deformity is, in bell clapper deformity, it is high investment of the tunica vaginalis. What is happening? Okay, you know I am very poor at drawing, right? Okay. Okay. The testis, which has to be normally like this, now what it is going to look like is this bell clapper deformity. So the tunica vaginalis is going to be lie in the uppermost part, means high investment of the tunica vaginalis is seen. That we are calling it as a bell clapper deformity. This bell clapper deformity, due to this bell clapper deformity, there is a risk of torsion of the testis. Okay. Now, after looking at the predisposition, now coming to the clinical features or the clinical presentation. What is the age of presentation of torsion testis, it is around 10 to 25 years of age. Between the age group of 10 to 25 years, we are going to see this. Okay. What is the main complaint the patient is going to come to us? Obviously, there is torsion. Torsion means there has to be pain, sudden pain, sudden pain in the testis, severe pain in the testis, sudden severe pain in the testis. Write it down. Sudden severe pain in the groin region. This is how the patient is going to present to us. On examination, if you examine the scrotum, on examination, you can see it as swollen. It will be swollen, and when you palpate, there will be tenderness. Okay, there will be, scrotum is going to be swollen and there will be tenderness in the scrotum. You are going to notice on examination. Now, testis, when you palpate, you can see testis is going to seems to be higher within the scrotum. Compare it to its normal location, testis seems to be at a higher level. Why? Because I have already shown you here the testis. When there is high investment of tunica vaginalis, testis is going to lie at a somewhat higher level. That is why you can feel that the testis is going to be at a higher level within the scrotum in case of torsion testis. Even I told you the cord is going to be twisted. This is the main entity. So this twisted cord can be palpated. Okay, you can palpate the twisted cord also. And one more thing is cremasteric reflex is lost in torsion testis. Cremasteric reflex is going to be lost in case of torsion testis. So in simple terms, what we have seen in the clinical presentation is age group is 10 to 25 years. On scrotal examination, you can see that the scrotum is swollen. You can see the tenderness in the scrotum also. The patient complaining of pain, severe sudden pain in the groin region. Okay, scrotum is going to be swollen and tender. On palpation, the testis seems to be at a higher position than the normal. And even the cremasteric reflex is also lost. And twisted cord you can palpate sometimes. There is an important differential diagnosis for torsion testis. Here I am writing torsion testis, and one of the important differential diagnosis is epididymoorchitis. I will tell you only the differences. In case of epididymoorchitis, there will be urinary tract infection will be there. So due to this urinary tract infection, there is increased frequency of micturition, and there is even pain during micturition also called as dysuria. These are the features which are seen in epididymoorchitis, but you cannot see them in the torsion testis. Even you can see fever in case of urinary tract infection will be there. So fever will be there in epididymoorchitis, which is usually, mild fever may be seen in torsion testis also, but fever not seen. And one more differential sign called as Frehen's sign. Frehen's sign, P-R-E-H-N, Frehen's sign is negative in case of torsion testis. Frehen's sign is positive in case of epididymoorchitis. Sir, what is this Frehen's sign? If at all you are going to do elevation of the testis, when you elevate the testis. So elevation of the testis elevation of the testis, on elevation, if the pain is going to worsen, then the Payan sign is negative. It is a case of torsion testis. When you elevate the testis, pain is going to worsen in case of torsion, whereas in case of epididymoorchitis, the pain is going to be relieved. So if at all the pain is going to be get reduced, then it is a case of epididymoorchitis, right? I think you can understand the basic differences between the testicular torsion and epididymoorchitis. Even in torsion, I have already told you the clinical presentation, sudden pain and a severe pain. Whereas epididymoorchitis is not that sudden in onset, okay? It is somewhat gradual. Now, investigations in general, I told you it is a surgical emergency. I need not do any investigations. But for completion's sake, I am telling you, Doppler ultrasound I can do. What can Doppler ultrasound tell me to diagnose torsion testis? It tells me, Doppler tells me the blood supply, okay? So reduced blood supply on Doppler ultrasound is seen in torsion testis. Reduced blood supply you can see, okay? Now coming to how to manage a case of torsion testis. There is the treatment of choice is always surgical exploration, okay? It is a surgical emergency, you should always do exploration. So surgical exploration is the management. Why I am telling you this? Because by chance, if I intervene surgically and I am going to untwist the twisted cord, if I am doing this within 6 hours, 100% I can save the testis. Okay, write it down. If at all I am going to do this within 6 hours, from the onset of pain or from the point of testicular torsion. So the moment there is torsion, there will be pain. So from the torsion time, within 6 hours, if you are going to intervene, within 6 hours of torsion, testis is 100% salvageable. Write it down. Testis is 100% salvageable. And for your information, I am telling you, if I am going to delay the surgical exploration, okay, somewhat around 24 hours, then the chance of salvageable reduces to even 20% also. Okay, beyond 24 hours, the salvageability of the testis falls to even 20% also. That is why as much early as possible you have to do surgical exploration. Okay, what to do in surgical exploration means what I have to do. First thing, I have to give an incision in the scrotum. Scrotal incision I have to give. Incision types may vary, you need not know at your level. So any incision I have given in the scrotum. Then what I have to do, the first thing I have to do is, first I should not check for the testis. First thing is, there is already torsion, there is already twisting of the cord. So my first aim is, cord is untwisted. So first thing I have to do is, I have to untwist the cord. After untwisting the cord, now I will look at the testis. Now what I am going to do is, I am going to look at the testis. If at all the testis is viable, the testis can be viable, or the testis has already underwent gangrenous change. Okay, the testis may be viable or testis may underwent gangrenous change. By chance the testis is viable, I have to do archaeopexy. Sir, what is this archaeopexy? Archaeopexy means nothing but the fixation. Okay, it is nothing but the fixation of the testis I have to do. That is called as archaeopexy. Fixation I have to do with absorbable sutures or non-absorbable sutures. Yes, I have to do with non-absorbable. If I use absorbable, then after that in the future there is always a risk of torsion again. That is why I have to do with non-absorbable sutures. Not absorbable, I have to use non-absorbable sutures, and I have to do fixation of the testis called as orchiopexy, so that it is not undergoing torsion in the future. Now, if at all it is undergoing, if at all the testis looks gangrenous, what to do now? There is no other option. Okay, when the testis is already died, I cannot make it alive. Okay, it is always better to resect a gangrenous one. So I have to do orchidectomy. I have to remove the complete testis. Okay, and one more point I want to emphasize here. Please write it down. Orchiopexy of other testis is also done in the same operation as it can lead to torsion in the future. Very important point. Now, I told you, due to this bell clapper deformity, high investment of tunica vaginalis is the one which is causing this problem. So this is not a unilateral entity, even though the patient may present with a unilateral torsion, but this anatomical problem will be there bilaterally on both the sides. In the future, there is always a risk that the other testis may also undergo torsion. Why to take a risk? That is why orchiopexy of the other testis has to be done. Okay, whether you do, if by suppose this is the involved testis, this is the uninvolved testis. Involved testis, I may do orchiopexy if it is viable. I am going to do orchidectomy if it is not viable. Irrespective of what I am doing here, with the normal testis, I have to do orchiopexy always. Why? Because the anatomical problem which is there is a bilateral entity. So this testis also, even the normal testis also, is going to have a risk of torsion in the future. Why to take a risk? I have already done surgical exploration, so it is always advised to do the orchiopexy of the other testis in the same operation. Okay, now I think you get the point. What we have done here, management, surgical exploration. If at all I am doing this within 6 hours, 100% the testis can be salvageable. Now, first thing I am going to do the scrotal incision. After that, I am going to look at, the first thing I am going to do is I have to untwist the twisted cord. After that, I am going to look at the testis, whether it is viable or whether it is gangrenous. By chance, if it is viable, I will do orchiopexy, fixation of the testis with a non-absorbable suture. Whereas if it is gangrenous, I have to do orchidectomy. Whether I do orchiopexy or orchidectomy, I should always perform orchiopexy of the normal testis also, as there is a risk of torsion in the future for that testis also. Okay, this is how to manage a case of torsion testis. Now coming to the next question. Next question is about tumor markers. Tumor markers, if I go on discussing, it is a very large topic. I want to emphasize just a few important, 5 to 10 some important tumor markers, and what are all the conditions where we are going to see those tumor markers. I am going to enlist here. Okay, but still it is a vast topic only, but only the main ones, important ones, I try to discuss here. First thing is some hormonal tumor markers I will try to teach you first. HCG. First one is HCG. Where you can see HCG? You have already studied in gynecology, I think so. Gestational trophoblastic neoplasia. Okay, gestational trophoblastic neoplasms. In hydatiform mole, invasive mole, choriocancer, all those things are there, no? There you have already studied gestational trophoblastic neoplasia. You have already studied HCG is a tumor marker. And I have already taught you in the seminoma testis module, I have already taught you in non-seminomatous germ cell tumors, we can see this HCG. Okay, non-seminomatous germ cell tumors also, HCG is a tumor marker. Now coming to the calcitonin, I think everybody know this. Calcitonin, where it is? Very good. Medullary thyroid cancer. Medullary thyroid cancer. Next. You also know this. Catecholamines. Catecholamines. Tell me. Catecholamines and its metabolites. What is the condition? Pheochromocytoma. Pheochromocytoma is the tumor where we are going to measure this catecholamines. Okay, 24-hour urinary metanephrin and all those things you already know. Now ectopic hormones also I can check. I am not going into each and every ectopic hormone. Okay, ectopic hormone levels I can check in case of paraneoplastic syndrome. In case of paraneoplastic syndromes, I can see these ectopic hormones. I am not going into details about those. Coming to next. Alpha fetoprotein, very important. Hepatocellular cancer, HCC, liver. Okay, hepatocellular cancer, alpha fetoprotein is the tumor marker, and the other is PIVKA, PIVKA. PIVKA is also a tumor marker. You need not know at this. Carcinoembryonic antigen, CEA, carcinoembryonic antigen. Two important ones, colon cancer, pancreatic cancer. Colon cancer and pancreatic cancer, that is CEA, carcinoembryonic antigen. Maybe there with other GI tumors also, but important ones I am mentioning here. Next, coming to immunoglobulins. Immunoglobulins like light chains will be there, lambda, kappa and all those things. Within the urine, you can see all these things in case of multiple myeloma. Write it down. In multiple myeloma, you can see the passage of various immunoglobulins in the urine, right? Multiple myeloma. Next, prostate specific antigen. Prostate specific antigen. Prostate. Yes, prostatic cancer. Next one. CA125. CA125. Ovarian tumors. Especially some epithelial tumors and all you can see. You can write it down, just ovarian tumors. There are many, but still important ones I am mentioning. Various ovarian tumors, the tumor markers for each one of them are different. You can study them in gynecology also. Okay. What is for epithelial, what is for granulosa cell tumor, what is for yolk sac tumor, all those things you can study in gynecology, but here it is enough. CA19-9, colon cancer, pancreatic cancer, same. Okay, even still there are many more tumor markers, just I have highlighted few of them here. Okay, just try to remember these names. This is going to be a more than enough table. I have tried to highlight each and every important tumor marker here. Okay, try to remember this, that's fine. If you want to remember more than this, it's up to you. Now coming to next question. Fracture ribs. Refracture. Before going to refracture, I have already told you the management of a case of flail chest. In flail chest, what we have seen, there is fracture in 2 or more ribs at more than one place in each rib. We have already seen, and we have already discussed the management of a flail chest also. Initially to give oxygen plus pain control. If oxygen levels SpO2 are going to be less than 85, or PaO2 of the oxygen is less than 60 mmHg, we have to assume that there is respiratory failure, and we have to start the patient on, very important, intermittent positive pressure ventilation. Okay, the treatment is of choice is never the operative fixation of the ribs. It is the last option we have. Okay, we have already seen everything in flyal chest. Now that is why I am discussing only single rib and multiple rib fractures here. Flyal chest also I have already discussed there. You can add that also to here. Okay, for now we will start with the basics of a rib fracture, not a flyal chest. Flyal chest we have already seen. Now coming to the rib fracture, what are all the most common ribs to get fracture? Fourth rib to the ninth rib. Okay, fourth to the ninth rib are the ones which are most commonly to get fracture in a fracture rib. Now what is the most important consideration in rib fracture? It is not a fixation of the rib is not my concern. The main important consideration here is pain control. Very, very important. Whenever there is rib fracture, the first and foremost thing I have to do is control the pain. Pain control is most important. Sir, how to do this pain control? One option you have is intercostal nerve block. You can do intercostal nerve block also, but even better than this is epidural analgesia. Epidural analgesia is always a best method than intercostal nerve block. Suppose let us look at a single rib fracture. If at all there is a fracture of a single rib. Now single rib is not much a severe complication, it is just a trivial injury. Now what is the most common site of a rib fracture? It is at the costal angle. It is at the costal angle, or maybe at the middle of the shaft. This is the most common site to get fracture in a rib. Okay, what are all the clinical features you can see? You can see pain. Pain will be there on pain on breathing or pain on coughing. This is how the patient is going to present to us. Okay, what I have to do? It is just a single rib fracture. Analgesics I can give, and one more thing I can do is intercostal nerve block also. That is enough for a single rib fracture. But whereas coming to multiple rib fracture, you already know the diagnosis of rib fracture or the investigation in rib fracture is a X-ray, that you already know. Multiple rib fracture, I have already told you, rib fracture main consideration is pain control. Better to go for epidural analgesia more than a intercostal nerve block. Now I have to repeat a chest X-ray after 24 hours in case of multiple rib fracture. Okay, I have to repeat chest X-ray after 24 hours. The question is, sir, why I have to do X-ray again after 24 hours? Why? Because sometimes there can be late onset pneumothorax or late onset hemothorax also. To rule out late onset pneumothorax or late onset hemothorax, I have to get a chest X-ray after 24 hours, and during discharge also I have to do the same chest X-ray. After that only I have to discharge, after ruling out pneumothorax and hemothorax. And what are all the other things? I have already done pain control. Other things what I can tell to the patient has to do deep breathing. Okay, some breathing exercises I have to tell him and the use of nebulization, and chest physiotherapy. Okay, this is how to treat. Nothing much more to discuss in this topic. Okay, basically it is the refracture is always about pain control, epidural analgesia more than intercostal nerve block. Investigation is chest x-ray only. In case of multiple refracture, you have to get the chest x-ray even after 24 hours to rule out pneumothorax and hemothorax. Okay, you can train some chest physiotherapy is there, deep breathing is there, nebulization, all these things you can teach to the patient. Okay, this is about refracture. Coming to ureteric calculus. The question they have asked is about ureteric calculus, not the renal calculus. Okay, I am not going into each and every aspect of the ureteric calculus. Just I am telling you a very briefly what is ureteric calculus. Okay, now how the stone is going to come to the ureter? How? Because from the pelvis of the kidney, the stone is going to fall down. Okay, from the pelvis of the kidney, when the stone is going to falls down into the ureter, that is how ureteric calculus is going to be formed. Now there are if you look at the ureter, there are 5 major points of ureter where the anatomically normally only there is somewhat at 5 areas the ureter is somewhat constricted, and these 5 areas are the areas at which the stone can be impacted. Okay, what are all the sites of anatomical narrowing where the stone is going to get impacted? 1, at the pelvi-ureteric junction is the first site. Second one is when this ureter is going to be get crossed by iliac artery, crossing with the iliac artery, this is also narrow. And when it is crossed by the vas deferens in case of males, or broad ligament in case of females, this is also a site of impaction. And at the site of entry into bladder wall, okay, whenever it is entering into the bladder wall, at the entry also there is a risk, not only at the site of entry into the bladder wall, at the same time at the ureteric orifice also there is a narrowing. So ureteric orifice also you can write it down. These are the 5 major points of impaction in a ureter where the stone can be impacted. Next, coming to the clinical features with which the patient is going to present. We already know the patient is going to complain with the pain in the loin. So loin pain will be there. Loin pain, this pain is usually radiating to the groin. Okay, this is one feature. What are all the other features of this pain? It is severe in nature and it is sudden in onset, and just one thing, it is colicky pain. That is why we are calling it as ureteric colic, right? It is colicky in nature and the pain can be relieved by, very important, antispasmodics and NSAIDs. Okay, loin pain which is radiating to the groin, which is somewhat severe in nature, which can be relieved by antispasmodics and NSAIDs. Now you already know the investigations. I am not going into depth because these are the same investigations which I am doing in case of renal stones also. As we are going to deal with renal stones in a complete vast manner, I am teaching you ureteric colic only as a very briefly. Okay, what are all the investigations? Investigations are completely similar as that of a renal stone also. What are all the investigations I can do? I can do X-ray of the kidney, ureter and bladder. I can get an ultrasound. Very important investigation, NCCT. Investigation of choice for a renal stone is always NCCT. Okay. Even for ureteric stone, the better and the best and the gold standard investigation is NCCT. Next, intravenous urogram also I can do. After investigations, what are all the treatment options I have in case of ureteric calculi? Any stone, maybe renal stone or ureteric stone, whatever it is, the first thing the patient has to do is to have plenty of water. Why? Because having plenty of water, sometimes the stone itself may come out, okay, through the normal urinary during micturition also. That is why the most important is plenty of water intake. Advise the patient to take plenty of water. For pain, I have already told you I can give antispasmodics. So if I give antispasmodics and ask the patient to take plenty of water, this itself may cause the passage of the stone also. In clinical practice, we are using a alpha blocker. We are using a alpha blocker, that is tamsulosin. Tamsulosin is an alpha blocker which is used in this ureteric calculi. Suppose if all these things cannot treat the ureteric stone, what to do? The stone can be in the upper ureter. The stone can be in the middle part of the ureter. The stone can be in the lower ureter also. The moment stone is in the lower ureter, it is easy for me to do ureteroscopy and I can remove that. So if it is in the lower ureter, I have to do ureteroscopic removal. Okay. Now, if at all it is there in the upper ureter or the middle ureter, I have to do extracorporeal shockwave lithotripsy. Extracorporeal shockwave lithotripsy I have to do. Even in middle also, I have to do extracorporeal shockwave lithotripsy. What is ESWL? I will teach you in renal stones. But as of now, just write it down, ESWL, extracorporeal shockwave lithotripsy. Now, even if it is in the middle ureter also, I can do some ureteroscopic techniques to remove that. Ureteroscopic basketing. What is this basketing? Suppose this is the ureter and here there is stone. Okay. Now, I am passing here through ureteroscopy. I am passing here and this is going to have a basket. What is this basket doing? This basket is going to enclose the stone and we can pull the basket outside. So this is the ureteroscopic basketing. Okay. The stone can be in the first of all, what we have to do, plenty of water is advised. Antispasmodics are given. Alpha blocker tamsulosin can also be given. So I will try for medical treatment. If it is not working, I have surgical options also. The question is whether the stone is in the upper ureter, middle or the lower. Lower one I have already told you, I can remove it with a ureteroscope. How to remove the middle one and the upper ureter. In the upper ureter and in the middle ureter, I can do extracorporeal shockwave lithotripsy. Even in middle ureter, there is another technique called as ureteroscopic basketing. Okay, where I am going to passing through the ureteroscope and with the help of the basket, I can catch that stone and I can pull back the ureteroscope. With that, I can do removal of the stone. This is about ureteric stone. Thank you for watching.